they are attending the meeting via Zoom and that they are located in Wayne County, Michigan, unless otherwise stated when I call your name. Commissioner Marecki, Commissioner Dobb,
Here.
Commissioner Anderson, Commissioner Killeen,
Right here.
Chair Baker McCormick,
Here.
have a quorum present.
And we're just going to mark them as present, but due to the circumstances, or how do we want to handle that? Is Felicia on the line?
She's not, but we can mark them as temporarily excused because they may join the meeting.
Yes, I was going to say that.
Okay.
We'll just excuse them for this time being. This is Makisha again.
Great. Thank you. All right, Madam Clerk, the first item, please.
B, Chairwoman's remarks.
I do want to send prayers out to Commissioner Haddis' family. He lost his sister, and also send prayers out to those that were senselessly attacked, the Asian Americans that were killed and attacked. I do want to send my prayers out to them and their families. Thank you. That's it. Next item.
C, approval of the March 9th, 2021 meeting minutes.
I'll move approval.
Thank you.
Their support?
Support.
It's been moved and supported. All those in favor?
Aye.
Any opposed? If none, motion passed. Next item, please.
D, unfinished business. There is none listed.
Next item, please.
Item 1, under new business, discussion with Dr. Velva Bowles regarding the science of COVID-19 vaccines.
Thank you. So I'd like to welcome Dr. Bowles. I invited her today to our meeting because we all know how hard Detroit was hit with COVID, and of course we're seeking to stop the spread. But one of the reoccurring questions that I get all the time from constituents is, you know, what is this vaccine, or what are they? There's multiple vaccines out for constituents to take, but they're really unsure of what they're taking. So we just wanted to get some of the factual knowledge of Dr. Velma Bowles, who received her medical doctorate degree from the University of Pittsburgh, her doctorate of philosophy degree in health sciences from Concordia University. She has a master's degree in chemistry and a bachelor's of science degree from North Carolina State University. Dr. Bowles' primary instruction and research interests are on extraneous biology and chemical processes which impact public health. She has published several white papers. These white papers reflect the interest in the social economical driven issues and disparities of medical care available to Black Americans. Dr. Bowles is a consummate teacher, having served as an assistant professor in the Department of Biochemistry at Colorado State University, and currently an adjunct professor at Louisiana State University. Dr. Bowles has worked in numerous areas over her career, including as a senior scientist for Westinghouse, primary care physician in Louisiana, South Carolina, and Missouri, clinical medical director, certified medical investigator, laboratory medical director, visiting research at the Center researcher at the Center of Disease Control, and assisting in research on investigating hantavirus, Lyme disease, and dengue fever. So we want to welcome Dr. Bowes, and we'll start with the questions of if you can just explain the COVID-19 vaccines that we currently have, and how are antibodies also used to fight the vaccine.
Good
Dr.
afternoon.
Bowes?
Thank you so much for inviting me to speak to you this afternoon. To start with, I guess I'll give you the overview. There are over 60 vaccines now available. In America, we don't speak of those that are Russian or Chinese or other countries, but you need to know there are many currently available. The 4 top vaccines which are discussed in the United States include Pfizer, Moderna, AstraZeneca coming out of UK, and Johnson & Johnson, which, as you know, is an American company, but it's the Janssen pharmaceutical company, which is in Britain, that are the 4, which I understand that Donald Trump invested in and Joe Biden has continued to invest. To talk about the vaccines, Pfizer and Moderna both start with a unique formulation. Well, AstraZeneca does too, but AstraZeneca is different from Pfizer and Moderna. So I'm going to take them in order. Pfizer and Moderna start with a messenger RNA. And for those who know about the development of vaccines, we've never used messenger RNA as a starting stimulating molecule. So I like to be very basic and say, what is a vaccine? Many people I've spoken to have the false understanding that vaccines protect you. They do not. Vaccine stimulates your body to produce antibodies. And the reason I make that point is more under my clinical training. What I'm trying to make everyone aware, if your body cannot launch an immune response, a vaccine cannot do anything for you. So there's a basic understanding that when you get the vaccine, it is with the intent to stimulate your body's own immune system to produce antibodies. That is the intent. In the case of Pfizer and Moderna, using messenger RNA enclosed in a micelle, that's a laboratory term that means bubble. And the bubble that this particular messenger RNA is protected within is polyethylene glycol. And there was some controversy, not so much about the messenger RNA, that's a separate issue, but there are people who are sensitive to polyethylene glycol. And those who have allergies to the latex gloves, to neoprene, bee stings, peanut allergies, and so forth, would be more likely to have an adverse response to what we call the vehicle, which is the micelle, which the messenger RNA is being transported in. So messenger RNA has never been used before to stimulate the body to do an immune response. If you want the physiology, once messenger RNA is introduced into the muscle cell, because this is an intramuscular injection, there is an organelle called ribosome. Ribosomes every day, every second of our lives, see messenger RNA usually released from the nucleus of the cell. It will translate messenger RNA into a protein. And the vaccine for Pfizer and Moderna is they introduce the messenger RNA, the ribosome does its job, and the protein that is generated is a viral protein. And this protein right now was modeled after one of the spike proteins on the coronavirus. So once that foreign protein has been synthesized, the body's natural immune responses would start or trigger the production of immunoglobulins. So that's the simplest antibody response explanation. So both Pfizer and Moderna operate in those ways. The controversy, if you want to call it from a scientific point of view, the Moderna and Pfizer, because they start with messenger RNA, they must be held at very low temperatures, or the RNA, which is ribonucleic acid, will be deactivated. So transporting and storage of these vaccines gives some problems if you're looking at the rural communities where minus 60 degrees or minus 70 degrees for Pfizer, and they are saying minus 40 for Moderna. Those are all temperatures that are not standard refrigeration. That requires either liquid nitrogen or some specialized holding. However, they're doing 1,000 batch shipments. And once those shipments reach and you put them in your refrigerator at 41 degree Fahrenheit, you have 6 days that you must dispense the entire stock, or you cannot be assured that it's a still active vaccine. So that gives you some logistics issues, and it does cause some concern for rural areas where the temperature requirements cannot be met. In the AstraZeneca, that particular vaccine starts with DNA. And most of us know about the deoxyribonucleic acid from our CSI stories. We know that to be the blueprint. The controversy from scientific point of view in this particular vaccine is DNA is never introduced directly into a cell. Now you heard me mention messenger RNA is introduced. That's kind of a recognizable entity because the DNA in your nucleus usually releases messenger RNA. But the injection with AstraZeneca introduces a DNA strand, and that requires some extra manipulation by your cell to get the desired outcome, which again is the protein of the virus. So there's a number of people who will talk about the physiology, the absence of knowing what long-term consequence, and that may be all the skepticism and some of the controversy they had in Europe with AstraZeneca arises from scientists questioning, do we know long-term? I don't have the answer, but that I'm just giving you insight as to why AstraZeneca may be more or have been more controversial than the Pfizer or Moderna. Johnson & Johnson, however, went tried and true. Their vaccine is based on the very same vaccine that's been used for over 110 years. They started with the viral particle itself, and they, as we say, deactivated or attenuated it. And that is what is being injected into their patients. And that has been done for since 1910, when the doctor first got recognized for knowing that antibodies can protect a person. So if you've ever taken any kind of vaccination, yellow fever, polio, MMR, any of those, you will be getting the very same science if you take the Johnson & Johnson. The second thing that makes Johnson & Johnson stand aside from the other three is it does not require the extreme temperature standardization. It can be kept at refrigeration temperatures, and that lends itself for it to be distributed in more remote areas. And they do talk about third world countries and so forth, but its stability is the term laboratories use, is a much higher stability than those that start with the nucleic acid. So the questions I'm most often asked once I tell them about these 4 major vaccines, are they safe? The question of safety has to do with what we have known in the past. 5 to 10 years is what they've taken to make vaccines. What you should know is Pfizer and Moderna did not simply take 1 year to be developed. The first SARS outbreak was 12 years ago. And work at NIH under Dr. Fauci is what became Moderna. So the public or the media doesn't release it that they have had a decade of testing and a decade of experimentation and clinical trial potential. They simply say they put it under warp speed and now here it is. But the reality is there has been more than a decade of testing of various ways to transmit the virus. You heard me mention PEG, or polyethylene glycol, for Pfizer and Moderna. AstraZeneca uses a chimpanzee vector, and that gave, again, some concern to people. But they've been experimenting. They've been testing for more than a decade. So this was not a one-year development, despite the hype about warp speed. It did take more than a decade to arrive at these vaccines, because SARS-1 was 14 years ago, MERS was 4 years ago, and in the United States, we don't always hear through our news media the types of things going on that do not directly affect the United States. So coronavirus has been around and causing some type of disease in humans for at least the last 15 years. So I think that's the two questions. One was explain the vaccine. Oh, the other was antibodies. One of the things that I've tried to make clear when I speak is that the way in which we have approached the pandemic is very narrow focused. Vaccines, if your body is capable of responding, are good. But we have other things that could be equally good. And that would include monoclonal antibodies, some call it convalescent antibodies, but they are available. We have, if you look at what happened when Donald Trump was said to be positive, they took him into the VA and they gave him Regeneron. Regeneron is one of the companies that constitutively produces antibodies. If you are watching the news and you're listening to your healthcare persons, they tell you the current vaccines that we just discussed, Pfizer, Moderna, AstraZeneca, Johnson & Johnson, they are not approved for pediatrics under the age of 16. Now, a few people seem to pick up on that. They're saying, well, do children get sick? Yes. Can children be adversely affected by this? Yes. Well, what do they do? Well, Eli Lilly, and I hope you recognize the name, it's a major pharmaceutical company, been around a long time. I remember them giving out stethoscopes to the first-year students at University of Pittsburgh, and you ready for this? 1985. So I know they've been around a long time. They stepped up and said, we will provide antibody coverage to give passive immunity to children as needed. Now, I didn't hear that on the news, broadly announced. Few parents seem to know it's available. But then when Donald Trump, age 74, who has some comorbidities, was given a positive announcement, how did they treat him? With passive antibodies. They didn't give him at that time a vaccine. They gave him antibodies. So my comment or discussion with other healthcare workers is I would very much like to see that passive immunity be offered to people who A, may have an allergic response to any component in current vaccines, or B, they need to be immediately protected. The passive immunity is immediate. The vaccine takes 28 to 30 days. I don't know if people knew that. When you walk out of there after the shot, you are not ready because you haven't had time to make your own antibodies. And they tell you the reason you wait 3 weeks for Pfizer and then 4 weeks for Moderna is so your body will have started making the antibodies, and the second shot gives you what we call a booster, and it solidifies your response to that particular vaccine. So you have to be looking at a 30-day window and possibly 45 days, 30 days after the first shot and then 15 days after the second, before you can actually say, my body has had enough time to respond to the vaccine and make antibodies. And I should note also, Johnson & Johnson's a single shot. And that has played into some people's decisions because instead of the 3-week wait for Pfizer and a second shot and a 4-week wait for Moderna and a second shot, AstraZeneca is designed for single shot. Now, people talk about efficacy And one of the things as a laboratory investigator, I have to smile. I hate when news media starts making medical report. People say, what is efficacy? I said, okay, let's talk about effectiveness versus efficiency. And that is really what we look at in a laboratory. Is it effective and is it efficient? And they said, well, can you be more specific? And here was my example that many people have repeated. If you were to come upon a building that is locked, you can take a stone and smash the window and get in that building. That is effective. You enter the building. Or you can take a key and unlock the door and enter the building. They are equally effective. Now let's look at efficiency. When you smash the window, you've created what we call collateral problems. So the efficiency of using a stone to get through a window and breaking the window is so much less than using a key to open the door. Because once you're inside opening with the key, you shut the door, lock it back, and things are as they were. So effective means it gets the goal. Efficiency says it does not create a collateral issue. So that's the kind of thinking when we're doing laboratory assessment and we're doing clinical trials and you hear double blind, single blind, and so forth. We are looking, yes, it's effective, but is it efficient? And that's one of the things that the media never picked up on. They were doing all of these comparisons saying efficacy. This has 90% efficacy and this has this many efficacy. And I'm sitting back saying, okay, that's great. Now, how efficient is it? So if you think—
Great, thank you.
Sorry?
Oh, no, I was just saying, thank you for explaining all of the vaccines and how they work. And I think we have a thorough understanding of that. I just want to see if any commissioners had any questions at this point.
I have a question, Commissioner Marecki.
Oh, go right ahead.
Oh, thank you, Doctor. And I had to come in late. I was in another meeting, so I only heard you probably the last 10 minutes. I just want to clarify something. So you're saying the AstraZeneca actually changes the DNA, where the other two do the RNA, the Pfizer and the Moderna, and the Astra one actually changes the DNA?
Whether it changes or not, I have no idea. They start with the DNA that gets translated inside of the cell into the foreign protein. It's the starting material.
Okay, the DNA is the starting material. Okay, I'm glad I asked you that because I was like, that would freak me out if they were changing any of the DNA.
Well, that's freaking a lot of people because when you introduce DNA directly in a cell, that is not physiologically how the cell usually produces its protein.
Okay, all right, thank you. This has been very informative. Thank you. Thanks, Madam Chair.
Thank you, Commissioner Marecki. Any other questions from commissioners?
Yeah, Madam Chair, Kalina, a couple of questions.
Go right ahead, Commissioner Killeen.
Thank you, Madam Chair. And it's always a good day when ribosomes and PEG are in the discussion. So thank you for being here, Dr. Bowles. Doctor, I don't know how far you sound like a researcher, so I don't know how deep into some of this data you go, but I'm just going to ask a couple of questions. Do you have any data on the severeness of reactions that have come up since we have started vaccinating people? Do you have any of that kind of data?
Yes. Dr. John Campbell in the UK does a daily report that's called Update. And he does an exhaustive summary on what literature is available to date. He is reporting that the condition called cerebral sinal embolism, which is a very rare occurrence. I think there was a physician that died in Florida from it, and there's been at least one other death. And that was after the AstraZeneca vaccination. And they did an exhaustive look at all of the clinical trials that were available, and his numbers came out to be 4 in a million as the possibility of this happening. The thing that causes some concern among the clinicians is this particular cause of death is an anomaly. If you have a physician background or any healthcare background, they're showing that there was a drop in platelets or thrombocytopenia, while a concurrent blood clot in the brain in the cerebral sinus cavity occurred. And as you may know, and for those of you who don't, blood clots usually formed by having lots of platelets. So it is an unusual finding that you have few platelets and then you have a fatal blood clot incident. So there was some discussion. I think Dr. John Campbell, who is, I think, a retired physician and professor, does a daily report, and he did an exceptional summary if someone wants to hear the details of his discussion on what he talked about, which was deep venous thrombi, which occur in the legs that move to the lungs and heart and have resulted in pulmonary emboli and some heart failures, as well as the anomaly of the cerebral sinus.
Yeah, I really didn't want to get into it that deep, Doctor, but Dr. Hamami from the county has been to our committee. And a month ago or so, he opined that the number of severe reactions is about the equivalent of aspirin. Do you have comparisons for bad reactions to this vaccine as opposed to other kind of routine medical things that we do?
The risk versus benefit has no question. At this time, during this extreme emergency, the risk benefit equations that most clinicians and healthcare public health officers benefit outweighs the risk. The question or discussions where you can get your conspiracy theorists is we have insufficient data on long-term findings.
Yeah.
And that is where there's a gray area. If you're honest and you're direct and you ask me, Dr. Bowles, is this completely safe for 5 years from now? I would say the intent is yes, but there's no data that can speak to that.
That's right, yeah. But as we see right now, it's not, there's nothing unusual here in terms of reactions as compared to other. They all have
That is correct.
Yeah, so let's talk about mutants or the variants just for a second. COVID-19 already is a variant of the coronavirus. It just happened to be identified in 2019. So that's already a variant. I understand we have something like 3,000, maybe more variants that are out there right now.
The first thing, and I do this in a much more rudimentary group, coronavirus is not new. It's 6,000 plus years old. And it is normally a infection of animals or zoonotic. And there's multiple types of corona, the alpha corona, the beta corona. It happens, this is beta corona, and the mutation that allowed it to cross into the human species, yes, to answer your question, it's around us everywhere. What surprises many people, sir, is a common cold is a coronavirus. Yeah. And we don't think twice about it. Why? It doesn't kill people. So we get a stuffy nose, a sore throat, we cough a little bit, we get 3 days off from work, and usually we're back up and at it. And we'll even say to people, don't kiss me, don't get close to me, I have the common cold. Well, surprise, that's a coronavirus.
Right. And we have not seen as you know, Doc.
I needed to address one other thing. The variants now you hear them talking about are serious.
Well, that's the ones they talk about.
Yes.
They don't talk about the 2,000 or 3,000 that are not dangerous. That's just the way things are.
We have maybe 2,000 happening, or maybe more, but there are 6 variants that causes concern.
Right.
And the reason they cause us concern, the new one in New York City has a defect in a spot that gives it what is called an escape infection. And the escape infection means the protein that is being targeted usually with the vaccines that we are currently giving may not generate antibodies against this particular variant.
Right.
Also with the South African, It also, in the 501Y, that is where the defect has occurred, gives it a hyperinfectivity, meaning the original strain, if I were infected and 100 people in the room, there may be one other person who get infected from me. But with this variant, if I'm infected and 100 people in the room, there may be 5 to 8 people that pick it up. So the variants are significant in that they may still be able to infect the vaccinated people.
Yeah, and we don't know that yet. If you were to bet on it with your professional background, doctor, have we seen the last of nasty variants emerging?
Absolutely not.
Yeah, and I think that's the thing people ought to keep in mind. Right now, it seems that our vaccines can kind of handle these variants without too much of an issue. But the next variants could change the whole game.
Well, one of the drawbacks on the current vaccine, with the exception being Johnson & Johnson, is the messenger RNA codes for a single protein, single virus protein. So the antibody will only be able to recognize that viral protein. So as strains are different, the vaccination may generate lots of antibodies, but those antibodies may be useless against the new variant since it can only recognize a single protein. So that's the debate of the most recent international conversation.
Well, let's hope we don't get
Right.
that kind of a nasty.
Well,
but
in
it
Miami Beach, talk to
I
the
know,
kids
I
in
know.
Miami Beach.
Believe you me,
They
I know.
are currently seeding it and they're going to come home. They're coming home, folks. They're not going to live in Florida. They're headed back to the States.
Well, that's why they call it a
Well,
pandemic.
thank you so much.
Can I get one more in, Madam Chair?
Oh, sure. Go right ahead.
Yeah, see, that's the thing with a pandemic. It's going to go worldwide. It'll start in one place. Is there any good data out there right now, doctor, on what we're referring to as the long haulers? And I don't want to get into that too much today, but if you could provide some sort of a link or where to go, because it's just really emerging. I saw a thing the other day about how a third of the people that are recovered also are long haulers.
Mount Sinai University Hospital in New York, last check, had over 20,000 long hauler patients. You can call and ask to get on a list, but long haulers, for those who you don't know, are people who end up having mental fog, which is almost like dementia. Some people have extreme fatigue where they may have been marathon runners. They now climb stairs and are exhausted. Some people are showing a Guillain-Barré, which is a type of paralysis. And all of this has been linked to the viral infecting parts of your neural tissue, which is the brain tissue or your spinal cord tissue.
So we are
condition long haulers. Mount Sinai University is leading in that research, and I'm pretty sure that Mayo Clinic has just opened up resources as well.
Yeah, and I think that's just getting into our consciousness that it's a fairly healthy population percentage-wise, and I don't know what that is. So I'll track that down, but yeah, that's another thing here. Madam Chair, thank you for giving me the time here. Thank you, Doctor.
Oh, no problem. Thank you, Commissioner Colleen, and thank you, Dr. Bowles, for this wealth of information. I think we all learned a lot in this meeting. So if anyone would like to reach her, I can provide her information for further questions. Again, thank you. Would you like to have final words?
I just thank you for the opportunity. My joy is to try to get as much truth out there and dispel unnecessary fear.
Thank you. Thank you again for coming, and we will be in touch.
Thank you.
All right. Madam Clerk, can we move to the next item, please?
Item 2, an update from Dr. Mahana Hamami regarding COVID-19.
Hi, Commissioner. This is Carol Osterberry. Dr. Hamami is actually out of the country, so I do have an update. I too am having some technical issues, so I can give you an update by looking on my other, big computer here, if that's okay.
That is fine.
Great. And again, thanks for having us here. We like giving all of you our updates on our COVID response. And this, I think many of you have been aware that the numbers have been increasing for the numbers that we pulled from, last week, from March 14th to March 20th. We have seen a 37% increase in confirmed cases from the previous week. And this is the first 7-day period where we've had over 2,000 cases since right after the new year, January 3rd through the 9th. Total new deaths during this period has been 23. And we are, doing, testing is obviously continuing with this many, new cases. Oh, sorry. So yeah, new daily counts as of March 20th, new cases 263, deaths 5. And again, our top 5 communities during this period: Canton Township, Livonia, Westland, Taylor, and Dearborn. When we look at our chart graph where it shows that trend line is going up. And with the, the way the trend line that we prepare, we have, we've reporting period from 173 cases per day to now 273 cases per day. So, and that's, an increase in an average number of cases per day by 100. So again, I'll say that again, the 2-period moving average has increased during this reporting period from 173 cases per day up to 273 cases per day. Interesting, our demographics, again, the most common age range of who is, these new cases is back down to that 17-year-old. The range, we have seen ranges in cases between 0 and 94 years. The average age is 35.3. But when I look at this, it's that mode, what is the most common age? And it's that 17-year-old. As we have always, I think virtually since all of this, we're almost at 50-50% female and male. Then we do also look at the top 10 municipalities with 10 or more cases. And yes, Dearborn had 267 cases, Livonia 194, Canton 183, Taylor 136, and Dearborn Heights 131. Many, as we have been reporting out now for weeks, those same communities are there, they kind of move back and forth as far as who is the community with the top number of cases, but we consistently are seeing the same communities with those top number of cases. The positivity rate. So last week, positivity rate was 7.8. 2 weeks ago, it was 6.3. This week for Wayne County, our positivity rate is up to 10.2. Now, the state of Michigan has also been seeing that upward trend. The state of Michigan 2 weeks ago was 4.1. Last week, 5.2. And the state of Michigan now is up to 7.5% for positivity. I know. We are averaging about 3,200 daily tests. And we do have a slide in here that shows all of our testing, sites and locations. Yeah, 1, 2, 3, 4. We have 7, locations that we had set up, months ago, and they are, active, they're busy. So we do have a lot of testing opportunities for residents in Wayne County. Walk up, no appointment needed, no, charge. So our testing capacity is here and serving our residents well. We usually talk about the jail inmate testing that has continued, and we are seeing, again, with that jail, very low, this last period, 180 inmates were tested, 0 were positive. So our jail population with that very good aggressive testing program has stayed, we are right where we have been. Medical examiner's office census, just, to let you know, 203 bodies. The average daily census was 182. So that's, we aren't seeing the deaths. We're seeing that increase in the number of cases. We have a slide here, the school-related outbreaks. And this is really where we have been seeing since schools went back in session in March. And I don't think it's just Wayne County. That is where the, the outbreaks are happening, and our communicable disease staff is, working very closely with the schools about the outbreaks, the sporting events, the, practices. Myself, last night, I got a call from an individual. He was a referee. He was not the referee. He was in charge of a hockey tournament over the weekend, and one of the referees came up positive. So, he was calling, okay, we've got, a lot of kids who were exposed to this referee at this hockey tournament. Then, as you were speaking earlier to the previous guest about the variant cases. Wayne County, we do have 64 laboratory confirmed variant cases, and they are in many communities: Belleville, Westland, Livonia, Dearborn Heights. They aren't just in one community. And as we've been hearing, the variant cases are what are more contagious. It's just more transmissible. And as far as vaccinations, so our standing vaccination site, Schoolcraft College at the Vista Tech Center, our Wayne County Community College. We also have been, I know you're all aware, we've been going out into the community. For this week, we are going to be again for second doses out at River Rouge City Hall, Harper Woods, JF Kennedy School and E-Course, and at the Field House in Melvindale. And then that leads me to the next day is that opening day, that soft opening day for the Ford Field event. We actually have vaccine allocation that was then allocated out to Wayne County for us to do field clinics here in Wayne County, rather than having the residents have to drive down to Ford Field. We also are providing opportunities out here. We are going to be in E-Course this week, International Gospel Center, and again, also at that JF Kennedy School and E-Course. The communities, like we've done for the other vaccine clinics, are the ones making the appointments for those clinics. And today was our first day, so we are, out there in E-Course. Then we also, a lot of the questions about, where are we at with the priority phases? So things have progressed and, been progressing and changing. And I can say that for the groups that we are considering, complete, we have it on here on our chart here is ongoing, everything from educators, our public safety, law enforcement, those necessary healthcare, critical healthcare. We have been vaccinating the people in these groups virtually almost since the beginning. The educators, and when I say educators, I do mean anyone who works in a school district in Wayne County. Doesn't have to be necessarily a teacher. We have been vaccinating them since January and are pretty well finished up with second doses for all of the school districts. So, that really was a very good, aggressive and comprehensive campaign to get anyone who worked in education vaccinated. Our correctional staff, that would be here in Wayne County, our sheriff's deputies. Again, we started with them back in January, and we have been, getting them vaccinated, going right down to Division I, Division III jails and doing first doses and second doses there. We are people age 75 and older, and then also people 65 and older. We are in progress with those. As I've said, many of those community clinics, that's who we have been first reaching out to, are those seniors who are 65 and older. We now are going back and also having communities with those community clinics have individuals 50 to 64 years of age. So again, continuing through our groups and also, lowering that age as far as who are the priority for getting the vaccines, because we are getting the vaccine into people's arms. We will be starting this week with the agriculture and food processing workers. Also, I know 2 weeks ago, Dr. Hamami spoke about the online registration. It is there for individuals who are their children who have disabilities and or their caregivers, guardians, siblings. They can go online, register, then we'll contact them and make appointments for them. So that, and to clarify, that also includes the child with the disabilities as well as those who are their caregivers, guardians, or, you know, live with them in their home. And then, yeah, also then the disabled, and the disabled individuals. And now we are working with the jail and downtown for those who are actually in the correctional facilities, detained individuals. So then upon their release or discharge from the correctional facility, they will be getting the vaccine as well. And then everyone asks, well, what about the other groups, the other frontline workers? And, you know, we're looking next week, maybe the week after, to then be able to be expanding out for them. I know yesterday we had a conversation with the chairperson all about the contracts that we are working on for a call center. Yes, we have put out a formal RFP for call center services, but in the meantime, we are having what we're calling a stopgap call center, and we are working on finalizing the details of that with Thaw. Thaw being a entity or a nonprofit right here in Detroit. They have a call center, and we are working, I say, on getting those details finished up so that we can get Thaw up and running as our partner for a call center services. So individuals can call, then a call center live person will make the vaccine appointment for them, and they will be making the first dose appointment and the second dose appointment at the same time. So wanting to offer, more opportunities for our Wayne County residents to be able to, call someone and have an appointment made for them. And we will also be rolling out with that. The plan is then for an online, there are people who don't mind, who kind of enjoy going online and making an appointment, but we want to offer certainly first that first offer is for someone to call in and speak to someone to have them make that appointment. And with that, I will turn it back over to all of you for questions.
All right. Thank you, Ms. Austenberry, for that
Thank you.
report. Are there any commissioners that have questions?
I have a question.
Yeah.
Go right ahead, Commissioner.
Thank you, Madam Chair. Carol, if you could backtrack a few minutes ago, I didn't want to interrupt your presentation, but you talked about the positivity rate going up in Wayne County from 6.3 to 7.8 to 10.2, and the state going from 4.1 to 7.5. But what about the deaths through all this?
Right. Deaths have not been, we have not seen that it's not killing because of that mode age of 17.
Right.
So we aren't seeing it's here, but the fact that you've got the most common age, someone who's 17 years old, and my, personal opinion, CVS, Walgreens, that vaccine first came out and we were getting it into the arms of, those seniors and the seniors in the long-term care. So yeah, it's not, like I say, it's not like, the numbers have gone up, but because it is that younger age, we aren't seeing the death.
No, and I appreciate you saying that, because I think if people start panicking, thinking we're starting to do this again, we have to really look at that, because everyone is wearing a mask. I never see anybody without a mask. Now we're getting all these vaccinations in, and like you noted, the 65 who are more vulnerable than a 17-year-old are getting these vaccinations. So I think people really need to put this in perspective that this is not what has happened months ago when all this started. And again, the mortality of someone in that age group. Yeah, it happens where people get sick at that age group. My daughter's an intensive care nurse. It's
Mhm.
very rare though. It's rare and, you know, most of the time they survive it. So thank you for pointing that out because I want to make sure with my constituents, if they start like freaking on this, that this has to be put into perspective.
Right.
So I appreciate it. Thank you. Thank you, Madam Chair.
Madam Chair, I have a couple of questions.
Go right ahead, Commissioner.
Thank you. Carol, I'm sorry, can you go back? So you were listing, I think it was Dearborn, Livonia, and Canton,
Right.
top 3 communities. Can you give me those numbers again for for the cases?
Yep. So Dearborn had 267 cases.
Okay.
And this is
that,
and this
like,
is March 14th through March 20th is the time frame, okay?
okay.
So Dearborn had 267, Livonia had 194, and Canton Township had 183.
Okay. Because I represent Canton Township, so I'm not proud that we're on that top 3 list. So I do want to do a little bit of extra outreach to make sure that people are being careful because, as we just discussed, the death, we're not seeing the deaths anymore, but I am reading articles about the long-term effects of this disease. And I think there's just a lot that we don't know. And, I think that if people don't get sick, that's probably just, for the best. So we just want to keep those case numbers down as much as we can. My next question was about the vaccine clinics.
Yeah.
You mentioned the communities that we were doing this week. Is there a schedule for next week or the week after? Are we going to be rotating through? Because I would love to get some clinics back for Canton,
Right.
because we have so many cases here.
Exactly.
What is the plan for that?
Yes, good question. And so, as you know, we have been going out to the communities. And again, first for those 65 and over, and then the priority was based on the SBI. So we have gotten to, and I want to say this right, we've gotten to the communities for the 65 and older based on SBI. The state lowered the age to 50. So we even went back, did those, and we are now just about at the done with with all of the communities in Wayne for 50 and over in the community. Now, some communities, it was interesting. Some communities even said, hey, we're good with, we'll do the scheduling. We'll send our residents to Schoolcraft or to Wayne County Community. So it's either way. So yes, now we will be going back through, are there more where we can schedule, and it's worked very nicely, like a block of, I'm going to say Westland. They were at Wayne County Community College, and heck, I was there the day when the Romulus seniors were there, and it just, I guess I'm going to tell my own horror a little bit, it worked out really well for scheduling. And then even like at Wayne County Community, we were able to like separate. So the seniors who they maybe kind of move a little slower, and, we had them in one lane, and then we made the younger, more athletic, agile people go down the hall to the long walk. So it really, it works very nicely at both of our clinics. So yeah, we certainly are continuing to go through the list and then, coming back up. Yeah.
Okay, wonderful. So, because we had a couple days where we did clinics in Canton for Plymouth and Canton, and then we had some at Schoolcraft. So
and I remember that.
We're going to get back around to us. And then I think that was all I had. So thank you so much.
Great, thank you.
Thank you. Any other commissioners? I'm here now. My internet is up again. Thank God.
For now.
For
Madam
now,
Chair?
that's right. Yes.
Oh, and now you can see hands too. I see.
I can see Commissioner Anderson.
Yeah.
Go right ahead.
Thank you. Carol, I just wondered again for an update on the housing, senior housing complexes and when we're going to be, do we see any date coming up that we might be able to get?
Yeah, you know,
back?
right. That actually is a very good question. And as we are going through with our communities, and again, like I say, them back out, we are, you know, we then are contacting those senior housing, you know, be it apartment, independent living. I know we've done a few, and, you know, that will come back to us with certainly as we're making this next round.
So
I don't
you
really
said
have, I don't have any specific dates. I can't, you know, I don't know of any specific dates coming up.
So do
but I
we
will
have
keep
that,
Mhm.
that mobile unit yet?
The mobile unit, that's a very good question. As we, again, as part of our plan, and as I was saying with our contracting, we are looking at contracting with a vendor who has some mobile units. They actually have been used for testing. And so the idea being, can we ultimately get those converted for mobile unit, especially for those who are, you know, homebound and, or, you know, just cannot leave their home. We need to, you know, have our plan to be able to then get back out to those individuals and not even, you know, and my point being here, you know, not that they would even be of like an age category. It's just, it's someone who, you know, cannot leave their home. So yes, we are working on that. Again, the contractual piece, you know, needs to be all worked out so that we can, you know, have that another arm of community vaccination opportunities.
Okay, thank you.
Thank you, Commissioner Anderson. Commissioner Colleen.
Yeah, thank you, Madam Chair. Ms. Osterberry, I want to go back to testing here just briefly. Apparently testing has kind of flatlined a little bit, and it's still, I don't want people to forget about it. It's still a very important part of, because it's for contact tracing for you guys, gives you a little heads up on where new centers will emerge. Now I see the list that's on the county website of 8-10 places around the county, and I want to share that. But what I'm asking for you, Ms. Osterberry, is I think, boy, I could really use something that is social media ready. Don't send me any PDFs. I get a lot of good information, but I can't share it on social media. But I think just a little brief thing that why testing is still important and why we need to have this done as an integral part of, you know, everybody's getting excited. They think they see the end of the road coming. They think they do. And so behaviors have been changing a bit. And that's not going to be helpful. So I think something that emphasizes testing a little bit and why people should get it and why it's an important leg for driving a stake through this thing. So if you have something like that, I could certainly use it. Let's not forget about testing. Thank you, Madam Chair.
Thank you, Commissioner Colleen. Any other questions? Thank you, Ms. Osterberry, for your report. We can now move to the next item, Madam Chair. Madam Clerk.
Item 3, a presentation by Black Family Development and Star Vista on their function as care management organizations.
Yes, and I have to apologize for the delay here. We will go ahead and start with Black Family Development. Thank you. Do we have a representative here?
My apologies. I didn't realize I was still on mute.
Oh. Hi, how are you?
Good. How are you, Madam Chair?
Good, good.
Good.
Thank you so much for attending our meeting. It's been a long one, but I hope you learned some things today.
It's been a pleasure to be here. I do want to share, Madam Chair, that we did go ahead and send the presentation yesterday at 1:15 to the commission, but we just resent it at 2:22 because we understand that the commission receive a lot of emails. So instead of sharing screen, we can take a moment to make sure each commissioner has the presentation.
Okay. You are sharing the screen, or you're saying you're not? Oh, you want to make sure that we have, okay.
But I wanted to make sure each commissioner was able to view the presentation.
Okay, great.
And so again, we sent it yesterday at 1:15 under my name, and then we just sent it again.
Again, okay.
Just so that we pull it quickly at their email. We sent it at 2:22.
Yeah.
Thank you. Yes, you can go right ahead with your presentation.
Well, thank you for the opportunity to present to the Health and Human Services Committee. Again, my name is Kenyatta Stevens, and as the CEO of Black Family Development, I am joined today by my colleagues. You will hear from next after me, our CFO, Jane Fernandez, Dr. Latanya Shelton, our COO, and then Samantha Perry, our Vice President of Juvenile Justice. We won't be with you long. Today, we are pleased to provide to you a brief snapshot of how our love for Detroit, our love for youth and families, our love for neighborhoods is carried out in our agency-wide work, alongside of our commitment to individual level services in the care management organization that we lead, as well as our youth assistance programs. So I will begin in my role with a very high-level agency overview. As you see on page 5 of our presentation, at BFDI, our mission is to enhance lives. And to do that, we are grounding ourselves daily in activities that focus on our commitment statements. So ultimately, we are committed to being an agency of hope and healing for the youth, families, and communities that we serve. Commissioners, on page 6 is some demographic information. On average, we serve more than 7,000 individuals annually, representing a variety of ethnic and racial backgrounds. The links that you see next on page number 7 are live links to provide the commissioners with an overview of our work to support Wayne County youth and families. These links are visual illustrations of our work in trauma, boys and men of color, and feedback from consumers themselves. On page 8, we share that we are CARF accredited. CARF is the Human Service Industry Good Housekeeping Seal of Approval. BFDI is a licensed mental health and substance use treatment provider with services that range from prevention to intensive intervention. Our youth assistants and CMO youth benefit from these treatment services based upon their assessed needs. On pages 10 through 12, they speak to BFDI's philosophy that collaborative community engagement is one agency hallmark, and a second is rendering services directly in the homes and neighborhoods in which our families reside. Our staff partner with families with the intention of bolstering the resiliency skills that they already come to us with. Our goal across all 20 plus agency services is to help youth live safely in their homes, but better navigate the school and community risk factors that entice them into delinquent behavior, because sometimes our youth feel the need to use alternative means to survive. On page 13, BFDI's Eastern Wayne County CMO and Youth Assistance Program zip codes and service areas are enumerated for your pleasure. Our services decrease youth from experiencing juvenile justices, and they occur on a continuum of such. Starting on that continuum is our Wayne County funded First Contact program for the least risk youth who are at risk though, but still in least risk. Then we move up in the continuum to diversion services, and then finally up to the CMO services and intensity, and Samantha Perry will talk about those in detail. Our mission ultimately is to work with partners to avoid de-escalation by building our youth and community protective factors. And so then you will see on pages 15 through 25 that between our narrative that talks about the individual level work that our agency is committed to do, we've inserted photos about our community level work. And that's essential because it's the community level work that helps us to improve neighborhood conditions so that it decreases the likelihood of our youth being involved in conflict and criminal activities. Just so the commission knows, to do that kind of community level work, we do not utilize the funds that the commission has granted to us for the First Contact, YAP, and CMO youth. We pull those out of revenues from the agency just to make an investment back into the community. So some of those investment opportunities include our Eastern Wayne County Peace Walks. We are training Eastside residents to be restorative practices peacekeepers, and we align with school leadership to build mentoring, workforce development supports, academic tutoring. These are non-traditional services that undergird our use of best practice models to support the families and achieve strong outcomes. The best practice models are introduced on page 26, but Dr. Shelton will speak in detail about those models. And now next, I turn the table over to our CFO, who will talk about how BFDI well invests the resources that Wayne County supports us with to deploy towards CMO and YAP services.
Good afternoon, everyone. Again, my name is Jane Fernandez, and I'm going to be speaking directly from one page in the packet, or one PowerPoint, and that is slide number 28. And I'd just like to share with you some bit of history about the CMO program and how BFDI is measuring impact. In 1998, when the CMO started, recidivism was 33%, out-of-home care was 70%, and community-based care was 30%. And what we realized then, as we began to kind of embark on this great endeavor, was that the only way to make this work, the way to make our design work, was to first look at community-based care and see what we needed to do strategically to bend the curve to have community-based care increase and decrease, while at the same time decreasing out-of-home care, especially out-of-home care that at that time was in-state and out-of-state. So what we did was, as an agency, begin to wrap certain evidence-based practice programs around and wrap those services around the youth. For example, from 99 to 2009, we offered what's called MST, or multi-systemic therapy. And the impact or the cost benefit of doing that saved the county $225,000. Now, the importance of that is that the more youth that we have or can provide services to in the community, the less it costs for out-of-home care, and at the same time reduces recidivism. One of the major things that we did was actually reduce recidivism from 33% down to between 8 and 10%. That saved or had a cost benefit of $52.4 million since 1998. We've also done some things with positive youth development, including, and Ms. Stevens spoke to this earlier, restorative practices. And that has a cost benefit of $1.5 million. All of these service arrays and everything that you see in these bubbles in the second indicator is what attributed to a total cost benefit for the county of $59 million. And the importance of that, again, is that we've moved more youth into community. And as of our most recent data, we now have 62% of our youth and community, again, saving money on those out-of-home care costs. So how were we able to do this from 1998 to 2021? One, by leverage funding, meaning that once we looked at how to increase the community-based services, we then needed to look at the parameters of the CMO contract and child care fund criteria in terms of how the dollars are spent. So what that meant in the long run, to bottom line it all, is that we needed to leverage dollars to increase prevention support for the program. And in order to do that, we needed to leverage dollars with foundations, with different contracts that we have, with looking at restorative practices, looking at some of our City of Detroit contracts, looking at our behavioral health contracts to see how we could infuse the dollars that are in those contracts alongside the CMO contract to help support the service array that is so needed, because the limitations on the dollars that are used for the CMO provide excellent services. However, we needed to augment that with providing a different services in terms of increasing our community care percentages. We also needed to look at our UR care paths, meaning that we needed to address length of stay. Length of stay was almost double or a little bit over double back in 1998. And we've reduced that by half in terms of care paths and service delivery, while at the same time ensuring that we meet the needs of the consumers. And also by looking at the evidence-based programs and models that we use in order to assure a continuity of care. And that is my quick measuring impact summary, and I hope I did it in less than 3 minutes.
Thank you. Thank you so much for all the work that you guys are doing. I just wanted to have you here because I am fairly new to the commission and wanted to understand what you did and the value that you bring to our community. And we thank you for that. And thank you again for attending our meeting today.
Madam Chair, is it your pleasure for us to end our presentation there, or would you like more detail into specifically what the CMO and the YAP are doing?
Do any of the commissioners have questions at this point? I think you kind of summarized in the beginning of your presentation all the work that you're doing, and Miss, was it Flanders? Fernandez, I'm sorry. Yeah, and she really horned in on the financial end of it. So I really appreciate that information. Unless other commissioners have questions, and I think that will suffice. Any commissioners?
Yeah, Madam Chair, I just got a quick one here.
Sure, go right ahead.
You know, and I think focusing on the financial aspect as Ms. Fernandez did, you know, the Wayne County was handed juvenile justice, I think in '99, when the state got out of the business. And I believe they gave us the feds gave us 6-8 months to set up this whole CMO thing. And we got it together. And I think the numbers speak for themselves, not only the vision of the county to do this, but also our CMOs, of which one is here, how ably they have carried out this duty. And I think, and I don't know, Ms. Stevens, if you can exactly multiply times 5. I don't know if all the other CMOs have a similar number of youth that you do. But when you look at these savings and what it saved the county over the years, and we go back, I think, to basics, keeping people out of institutions, in their home, bringing services there, improve outcomes, and gasp, it's cheaper to do it that way. So, you know, I don't know if I need the details of the app and what you're doing there. I think the numbers speak for themselves. But I just wanted people to be aware of that history, right? That back around 99, 2000, the county had very little time when the state got out of the juveniles business. And we're not sending anybody to Boys Maxie again and making real criminals out of them. And that's just tremendous that we're not doing that. So thank you for all your work, Ms. Fernandez, Ms. Stevens, and thank you, Madam Chair.
Thank you, Commissioner Colleen. Any commissioners, any other commissioners? All right, if none, thank you again, Ms. Stevens and your team for stopping by, and keep up the good work. That's all I can say. Thank you.
Thank you very much.
All right, bye-bye. All right, and next up we have Star Vista. Is that correct?
Well, we are formally Star Vista. We've had a name change.
All right.
Yes, and as Commissioner Colleen so eloquently stated, we were formed in 1999. So I'm gonna give you a quick story as to what not only was services that we provided, and we saw evolution over time for the youth we were seeing. So in 1999, we were formed. We had 2 parent companies. This is the way this is our internal joke, is that.
I'm sorry, can can you just state your name and
Oh, I'm
title
sorry, I
for the
had it in
record?
the chat.
Oh,
Verdell
that's okay.
Thomason. I'm from Insight Youth and Family Connections. I'm the Provider Network and Program Services Director.
Thank you. Thank you so much. Go right ahead.
And I'm gonna beat my boss up. However, here we go. So how we started, we said Star Commonwealth, who served the boys, and Vista Maria, who served the girls. They were married. They had us, Star Vista. So in 2020, mom and dad got a divorce. So we had to find our identity. The child did. So we did a year's worth of strategic planning. And we looked at where we were and where we were going to be, where we wanted to be. And we also looked at the needs of our young people. And so we invested in some programs. We looked at how our young people were not completing school. That was one of our first community programs that we began. Check and Connect. It's an evidence-based program that we've been utilizing with our young people, where we work with them in their academics, behavior, and building a relationship with their parents and helping the parents navigate the school system. Of course, when I say work with them on academics, we know right now for the last year, it's been extremely challenging in making sure our young people are able to progress as they should at school. And so we do a lot of relationship building, helping them navigate the system, making sure they have laptops or tablets, because again, it is extremely challenging working with them virtually, but our numbers are good. Our goal is 75% of them having improved outcomes. We're at 43, but we when working virtually. And Commissioner McCormick, I sent you some flyers for our programs. I can send you some more information. I actually sent it, I think about noon today. Did you receive those?
Okay.
The overview of the programs?
No, I have not yet. I had internet problems all morning, so I will take a look at that.
And so you have information on our school completion program, which is Check and Connect. We also have other programs. It's a Journey to Success program. It's our second most recent program, where we look at career pathways for our young people. We're doing all of this virtually. We have a mentoring program, and then we have after school activities where pre-pandemic, we were doing basketball, having mentors come in and work with them. And so you have this information.
Now, have your numbers increased at all?
Numbers
or of youth?
Our numbers are around 100, 114 a month. I have our February report here, and our census was 114. And so they have increased slightly, yes. And we have.
So we were concerned about the behavioral health of our youth. The Wayne County Commission Youth Council actually just came up with a resolution that talks to some of the issues that young people are having right now. And I was just wondering, do you see any of that or the uptick in issues?
We have seen an uptick. We just had a meeting yesterday morning about addressing those issues, because we've been seeing them virtually, and we are looking at, we're going to start back doing our face-to-face. We have to, we're looking for different solutions to the problems.
Okay. All right, well, thank you so much.
Well, we have one more program.
Oh, go right ahead.
That we just received funding for, and it's substance use disorder funding that we received from DWIN, Detroit Wayne Integrated Health Network, and where we work with young people 7 to 17. And we are working with the families at a school in Redford. And I sent you, that's in the packet I sent you.
Okay, and I will also forward it to the other commissioners if you have not as well.
But what I will do, I will put together a packet and have it for you tomorrow.
Okay, great.
Okay.
All right.
Okay, any questions for me? And I just want to say how we partner as CMOs. We received training from BFDI, the restorative practice training. So we are partners in this. You know, we don't work in silos. We really use each other's resources and making sure that our network of providers and youth are receiving the same service.
Great. So it's good to know that our dollars are being well spent. Any questions from commissioners? Any questions from commissioners? And I see none. I want to thank you, Ms. Thomas, for coming and addressing the Health and Human Services Committee today. I know it's been a long meeting. It's not usually this long, but we had a lot to cover. And thank you to Dr. Bowles for her very informative conversation today. We in Wayne County, I think we deserve to know the facts, and that's what we wanted from this meeting today. So we want to thank all of our guests, Ms. Stevens also, and thank you. Thank you for coming today.
Thank you for inviting us. I appreciate it.
All right. All right. So, Madam Clerk, we'll go to our next item.
F, such other matters as may be properly submitted before the committee.
There are no such other matters. Next
Public
item, please.
comments.
Okay. Any public comments from anyone? Would anyone like to speak to any of the issues we have addressed today? Okay, any emails, Madam Clerk?
No, we have not received any emails.
All right, then if there are no comments, we will move to the next item.
Adjournment.
Is there a motion to adjourn? No, we want to stay in the meeting longer?
Oh, I'm on mute. I'm moving adjournment, Madam Chair.
Support.
Thank you both. Meeting adjourned, and thank you all for attending today. It's been a good meeting. You all be blessed, okay?
Bye-bye.
All right.
Thank you, Madam Chair.
Thank you. Thank you so much.